Yeah. So in previous years, the teamwork at handover station wasn't usually tested. It used to come out, I think, every second year, every third year. So it wasn't one of those extremely high yield stations. But with the new format of the exam split into stage 1 and stage 2, I honestly believe that stage 1 will be really, really focused on communication. The reason for that is there's not much else that you can test in a virtual environment other than communication skills. Okay, so I just want to go through the result of the quiz that I sent yesterday. I'm not quite happy with the results, but it's really good because it gives me a bit of background knowledge on where to focus on today. So the first question was, what's the best method for handover? And a lot of people said the S-bar method. And I know that you might be familiar with certain types of methods, but the correct answer was that all of the above is perfectly acceptable as a method used for handover. But I'll get into that a bit later. So the next question was, how many cases for handover we usually get in the station? One person said 5. That is way too much. You cannot ever get 5 stations to hand over. That's simply too much. You cannot fit that into 9 minutes, okay? The answers of 2 and 3 were right. I would say that 2 stations is what you will get, because that's the way it was tested in the past. The typical amount is 2, but it can go up to 3. What is an essential piece of information needed at handover? Very happy everyone, well, the majority said the patient's NHS number, which is fantastic. You don't really need to know the patient's name. Is the patient's name good to know? Yes, obviously, but if you have the patient's NHS number or hospital number, you can go to any computer, plug that in into the system, and all the patient's demographic details will come up. So you don't really need the patient's name, but it's something good to have. This was a bit worrying, a bit concerning. When should you leave a handover meeting to end your shift? And what does everyone think?
Permission from the reg?
Not really.
I'm with the 60%.
When the meeting is over.
When the meeting is over is absolutely correct. So handover is protected time. During that time, you'll get bleeps and calls or whatever system your hospital uses. If you get an emergency bleep or a crash bleep within that protected handover time, the person who is currently holding the emergency bleep will take the call. Okay, and that is the only time you interrupt handover, is to answer a crash bleep or crash call. So everyone goes to that meeting. So the incoming team goes to that meeting and the outgoing team goes to that meeting, and everyone signs in, and handover is very structured. So you hand over to your appropriate grade. So the F1 hands over to the F1 or to the A&P. The F2 hands over to the F2, SHO to SHO, and the registrar will give a detailed handover to the registrar. Okay, consultants do not attend these meetings. Certainly the on-call consultant doesn't attend this meeting. So you should only leave that meeting once the meeting is over, even if you have handed everything you need to hand over already, or if there's nothing to hand over, or if no one needs to hand over anything to you. Okay, is that point really, really clear?
Yes.
Just to double check, so we still need to go to the handover meeting, even if we don't have anything to hand over, or no one has to hand over anything to us?
Precisely, exactly.
Okay,
okay.
Thank you.
Yeah.
And we can only leave
you
that.
Still have to go. Exactly.
Right.
You still go to the meeting, even if there's nothing to hand over, and you exit the meeting once the meeting is over. So if, for example, if handover takes from 9 o'clock to 9:30, you will be there in that meeting for half an hour, and then you will leave at the end of the meeting.
Okay, thank you.
Yeah. Anything else? Oh, okay. So next question is kind of an SJT-ish kind of question. And you're the FY1, a nurse is really concerned, escalated the patient to you, you've assessed the patient, decided the patient is really, really poorly, and you need to ask for advice from your senior. So who do you call? A quarter of people said the on-call consultant. Again, the on-call consultant is not going to be too concerned. And if you go directly with this issue to the on-call consultant, they will ask you, why didn't you go to the med-reg? The medical SHO, which is the F2, the IMT, so there's not much of a difference between F1 and F2, except the F2 has a bit more of experience compared to F1, and the IMT SHO has more experience than the F2. They will do the exact assessment and recommend the exact interventions that an F1 would have done. So you would have assessed this patient, you would have got a list of observations and clinical examination findings, and you would have already done things like giving them oxygen, fluids, taking blood cultures, maybe an ABG, giving a stat dose of antibiotics, whatever it might be. So they will do the exact same thing. The only person that can really help you in the situation is a med-reg. Yeah, so the med-reg will talk to the ITU reg, and they'll do an appropriate grade transfer. So it's most appropriate for the med-reg to speak to an ITU reg. It's not really appropriate for an F2 or an F1 to speak to an ITU registrar. It has happened in the past, but in the exam, if you are asked a specific type of question like this, for whatever reason, you say you will escalate to the med-reg, and the med-reg will liaise with the ITU team for ITU assessment. Okay, so any questions on that?
Yes, I have a question. You've mentioned that we should not be expecting this type of question on the exam, or should we?
You shouldn't be expecting it, but be prepared for anything. So I will give you the necessary knowledge that you need, and I will tell you what's most likely and what's least likely. But this is an exam, and the possibilities are anything under the sun. Okay?
Right, and regarding this, so to answer this question or similar questions, we would need to really know the ranks of medical staff, right, at the UK hospital. Could we quickly go over that?
Not in the session, because that's not
Okay.
the focus of the session. This is more something that you need to know for your SJT. Okay, so this is so yeah, so the types of staff and their roles are really, really important. You need to know this for your SJT.
Okay, thank you.
Okay, it's not really the focus of the session. So the last question is, you're on a surgical ward, and it's a handover question. The colleague has been really busy. She's really tired. All she wants to do is go home and sleep. And what do you do in this situation? Not very happy with the results of this. So a lot of you said, ask her to write down a list of jobs for handover. That's not really appropriate. So what you need to ideally do is ask her to stay back for a few minutes so that you can have a proper verbal handover. Okay. The problem with asking her to write down a list of jobs, she will write down what information she thinks you should have. And that information is not necessarily what you really do need to have, if that makes sense. So that's the problem with people handing over a jobs list as opposed to sitting down and discussing things face to face. Okay, any problems with that question?
Nope.
So some people are messaging me on the Telegram group. Please send your messages in the chat, okay?
Can you just repeat the last question? I didn't quite get that, but the last question of the questionnaire.
In terms of the answer or?
The answer, the answer.
So the correct answer here is to ask her to stay back for a few minutes, and not to ask her to write down a list of jobs for handover. Did you want me to elaborate on why the answer is incorrect?
Yeah, please.
Yeah. So if you ask someone to write down a list of jobs, they will write down a set of information that they think you should know. And the information that they write down is not necessarily the information that you do really need to know in order to do that job. Do you understand that?
Yeah.
Yeah. So they can write something about Mr. Z on ward 17 needing so and so, and hand it over to you. You don't know who Mr. Z is. You don't know why he's coming to hospital. You don't know why he's on ward 17. You don't know what's been done, what's already been done, what the working diagnosis is. You know nothing of that, but you've been asked to do a job. Okay, so that's the problem with handing over a list of jobs as opposed to sitting down face to face and getting a proper handover from someone. Okay?
Can I ask a question?
Yeah, sure.
I'm just wondering, I thought normally jobs are handed over as well. So are you saying that when you're doing a handover, you're not meant to hand over jobs, or is it going to be a case of definitely having a verbal handover and possibly handing over jobs?
So ideally what happens is people write down jobs on pieces of paper and take them around because it's very difficult to remember the 20 different patients you have and you've been called to do tasks for. When you're sitting down at this handover meeting, you're sitting down in a big room and everyone has their turn at, saying what they need to hand over. And when you say that, you address it to the entire room as well as specifically the colleague that you're handing over to. So you say, it was a fairly busy night. I received a few calls from so and so wards. I've managed to do this, and this. However, I don't really have time to do this, or I need to hand this over. Can we go through the list quickly? So you say, I have patient XYZ on ward something. They were admitted with the chest infection. They've been given antibiotics, fluids, but the blood pressure is a little bit low. Can I just ask you to go back in an hour and a half's time to recheck that blood pressure because I've asked the nurse to give a bolus. Okay, so something like that. And the person on the other side receiving the handover, because it's the start of your shift. So the sensible thing is write it down so you know what you have to do and where you have to do it.
All right, thanks. That's helpful. Thank you.
Yeah. Okay. Any other questions?
So John Wayne is saying something like, I think being up all night is a hazard to patients. So I answered, well, communication skills like this will only take a few minutes and I understand you want to go and blah, blah, blah. And he said this would go against GMC, good medical practice. And I'm not sure what he means by this.
I'm not sure either, because doing a night shift is very typical. So you'll do 12.5-hour night shifts, and that's a typical shift pattern. So that's the European Safe Working Directive. So that has been regarded as the NHS as a safe working pattern. You can't stay awake for 12.5 hours on your night shift. We do it all the time. So what was his answer there? Because one person answered, let her leave, and if there's a problem, call her to clarify. The problem with this is, I think she'd be really pissed off if you call her when she's gone home to have a nice long sleep, calling her about patients she saw 5 hours ago. So that's the issue there. It's not appropriate at all. I'm not sure if my answer made any sense or.
Can I ask a question, please?
Yeah.
I'm not quite understanding. So how the task itself will look on during the exam? Will we have a note with a patient's details to possibly ask the question on handover, or how the task itself is going to look on the exam?
So you will be talking to someone. I haven't included exact an example, but I have two practice stations in my session today. I haven't included a handover example,
Okay.
because I've explained it really well. I think I've explained it well. So you will be talking to someone.
Yeah.
That someone will be a junior doctor.
Okay.
You can either take a handover or you
Right.
can give a handover. It is
Okay.
typical that you will receive a handover because of the
Right.
examiner's question at the end. All right?
Okay.
So that person who is handing over to you will be verbalizing everything. And you are allowed to write things down if writing things down is more your style.
Okay. Yeah. So I won't have any patient's details then? Won't be given any patient's details?
Yes, you will be given patient's details, but only if you ask for it.
All right. Okay. Thank you.
Yeah. So you will be given the answer to everything that you ask for, but you must ask for it. You won't be given something that you don't ask for.
Okay, I got it. Thanks.
Yeah. So coming back to the handover station in general, as I explained, it will appear now on your exam. In stage 1, it is extremely high yield. There are typically 2 cases, but not more than 3. And the main reason for this is there's just not enough time. You cannot take a handover for more than 3 patients in 9 minutes or under 9 minutes. Okay. The examiner's question, the examiner at the end of the station will ask only one question. And this question has always been, who will you prioritize and why? Just one question. Then you will have to justify what you've prioritized. Okay, so if you say patient A instead of patient B, I'll go and see patient A first. You'll have to justify why you're going to see patient A as opposed to patient B first. Okay. In terms of handover, you don't need to know the entire long story about a patient. Patients come with life stories. You don't need to know that. You just need to know the absolute essential information. So what do I mean by this? So it's just to check in. Is everyone following me? No technical difficulties. Can hear me and see me just fine.
Perfectly.
Yes, we can.
Yeah.
Thank you.
Yeah.
Fantastic. Fantastic. So essential information, right? So you have a patient. It's got a long social history. Yeah, quite a few social issues. But he's right here, right now, in the hospital. What types of elements in the social history do you think is important for you to ask about, or for you think the person giving you handover should mention?
So we'll need 3 identifiers, so name, date of birth, and hospital number or NHS number, presenting complaint. So if like ops, if they're stable or unstable maybe, and what needs to be due or chased, and maybe working diagnosis.
Yeah, fantastic. Yeah, that's brilliant.
History, I think we may ask that if his relatives been informed and there's somebody with him right now.
Yeah, all of that is really essential information that you need to know in order to do your task. In terms of a social history though, you don't need to know what type of house the patient lives in, okay, whether they're on benefits or not, okay. If the alcohol and drug history is significant, if the alcohol and smoking history is significant, I would say you don't really need to know about the smoking history either for handover. And what you do know need to know in a social history is. So if they're elderly and if they need any social input, like from carers, yeah, that would be useful to know. And if they are on any illicit drugs, yeah, in terms of the social history. If they're an alcohol abuser and a social history, and if you are receiving handover about a gastro patient. So it's kind of the essential information. You just kind of have to eyeball it. If there's certain things that I specifically haven't covered here, but you think when you're doing that station, you should be asking about, because you think that information is useful for you to know how to be able to do your job, then by all means ask about it, okay? I've put this next bullet point in bold because it's really important. So you can be getting a handover, you can know everything about this lovely patient that you've never met before in your life. But what do you want me to do? Or what does the doctor want you to do? So in the handover, you must specify and you must specifically ask, what do you want me to do? What is the task? Okay. Do they want you to go and reassess the patient? Do they want you to chase a result of an investigation? Or do they want you to have a discussion with them about something? So that task must be clearly defined. What do they want you to do? So in the handover station, I just want to say that not everyone is nice. Usually, unless it's the angry patient station, everyone is very nice. Sometimes the handover station, the actor is specifically instructed to be difficult, and you just need to be aware of how to deal with that. Can anyone give me an example of how to deal with a difficult colleague?
Stay calm, obviously. Stay
calm, yes, precisely.
Listen.
Listen, yes, they might be very frustrated and they might just need someone to listen to. Yeah, that's brilliant.
Empathize.
You could say that I can see that you're really tired and can't wait to go home.
Yeah, acknowledgement, yeah.
Maybe
don't be judgmental,
be a little with here that, oh, I know you must be really tired. How was your shift? How did it go? Like a few friendly questions.
Yeah.
Someone in the chat says yell.
So those are all excellent. I'm very happy hearing those answers, because yes, absolutely, you listen to them in a calm manner. You don't try and escalate things, you don't try and challenge them, and you say, listen, I know you're really, really tired. It must have been a horrible shift. I'm really sorry about that. The good thing is that it's over, but can we please sit down and do a proper handover? I promise it won't be more than a few minutes, just to ensure patient safety. So make sure you mention patient safety. When the examiner hears patient safety, they'll be very happy. They'll give you that tick on the box. Yeah? So, does that make sense?
Yep.
Yep. In terms of handover techniques, there are various different methods that are used, and they are tended to be favored by certain types of people over others, and it does not matter. It does not matter if you use the S-bar technique or the SOAP technique or the ATMIST or the gap bad mess. It does not matter, as long as you make sure that you get all the essential information. Any questions on that first bit?
Nothing on the chat.
Nothing. Fantastic. Let's go on. So the S-bar technique, you might have come across on this before. If you go into any NHS hospital, there's usually big posters about the S-bar technique over the nurses' station. And it is the standard that's used by nurses in the NHS, okay? So when nurses hand over to each other and when they hand over to a doctor, they will use the S-bar technique. Also, when they're handing over, for example, from AMU to a medical specialty, you'll tend to note that they are using this technique if you listen to them when they're on the phone, okay? The gap bad mess, method is used in my study guide. It's a very good method. It's a bit more comprehensive than other methods. And the reason for this is it can be neatly compartmentalized into everything that I think you should ask in the station. Yeah. In terms of other methods, there are various other methods. You may or may not have heard about this. ISOBAR is another technique usually used by nurses as well. The ATMOST is used by emergency services. The paramedics use this to hand over, and the SOAP technique, you should have heard about this before. There are many, many others, and too many others to name. If you do have a technique that you're used to, just use it. Yeah, you don't have to switch to my method. Okay, if you're used to it and it works for you and you get all the essential information that you need, use it. Yeah. Any questions about that?
For the exam, do we need to know all the different types of methods, and will we be asked to use a specific method in this session?
No, no. So you can use whatever you want. Okay, so as long as you get the essential information.
And what can you just tell us what is the main things that we shouldn't miss, just regardless of the method that we use?
Yeah. So I'll get to that.
Okay, thank you very much.
In the next few slides. Yeah. So I've used the GAP-MAD-MESS method, and underneath that, I have outlined all the essential information that you need. Okay. So general details. You need to know the demographics of the patient. It doesn't matter what you get, but you need at least any 2 unique patient identifiers. So your name, your age, and your date of birth is not a patient identifier. Yeah, I would ask specifically for an NHS number or hospital number. Okay, the reason that names and date of births are not unique identifiers, names are very common. We share our names with lots and lots of other people. Date of birth, I'll probably share my date of birth about 70 or 100 million people in the world. So it's definitely not unique. Okay, so get the NHS number or the hospital number. Okay, admission, when do they come in? Okay, what time of the day? Was it at midnight? Was it in the afternoon? Was it in the morning? And how did they come in? They come in through A&E? Was it a GP referral? Okay, were they blue lighted in? So that's important information to know. When and how did they come in? Why are they here? Why is this patient in hospital? Okay, you need to know this. And just a little bit about the medical history. Some patients have 20 to 30 different medical problems. You don't need to know all of them. Just the ones that are relevant to the job you're being asked to do. Okay, in the exam, they will not give you a patient with 20 to 30 medical problems. It will be like maybe 2 or 3, hypertension, heart failure, maybe kidney disease, past appendectomy, something like that. Okay. This portion,
they're asking what's the, so if one identifier is the NHS or hospital number, what's the second one?
The other number.
Okay.
Yeah.
And my other question is what's to be blue lighted in?
Oh, blue lighted in is just on an emergency basis. So the paramedics put the blue light on and they're rushed into A&E immediately.
Thank you.
Yeah, so there could be a walk-in to A&E and they wait for 4 hours to be seen, or they get blue lighted in, which means they're really, really ill.
Thanks.
Okay, so this part is the general details that you need to know. Yeah, any questions? Nothing?
Sorry, just to be sure, NHS number and hospital number are 2 separate numbers, right?
Yes, 2 separate numbers, yeah.
Okay, thank you.
Sorry, do we need to listen to handover from the beginning to the end and then ask the questions? Or if you feel that, for example, in first part, in gaps, they're missing something, ask questions straight away.
You ask the question straight away. Okay, do not ever wait to ask a question, because you have no guarantee that you have time to ask a question.
Okay,
there's no guarantee that you will remember as well to ask a question. Yeah.
Okay.
If you have any question, just ask it.
Okay, thank you.
In real life, I don't think they'll be cruel enough to do this in the exam. In real life, you tend to get a bit of rambling handovers. So if you ask your question and direct it to what you want to know, it's always better for you. Yeah?
Okay.
Happy?
Yes, thank you.
Yeah, anything else?
Nothing on the chat.
Fantastic. Let's move on. So next portion of the mnemonic, background. Tell me a little bit about them, okay? Were the family involved? Do they have any important allergies? So allergy to penicillin or allergy to any drugs? Peanut allergy is also really important to know because some creams, like the Naceptin cream, is made with peanut oil. Okay, are they eating, are they drinking any relevant travel histories? I have traveled outside of the UK within the last 3 months, and any relevant social history. In terms of the assessment, give me some vitals. What's the blood pressure, heart rate, respiratory rate? Are they saturating okay on room air? Any relevant examination findings? Was there palpable mass in the abdomen? Do they have some crackles and auscultation of the chest? Any unequal pulses? Any relevant examination findings? Any investigations that were done and the results? What was the result of the full blood count? The LFTs, thyroid function, anything like that, and what was the result? Diagnosis, what is the working diagnosis? Has the senior seen them? Has the team seen them as yet? And what's the working diagnosis, or what's the provisional diagnosis? I think this part is fairly straightforward, but does anyone have any questions about it?
Nothing on the chat.
Right, let's go on. The last bit, the management. What has been done for this patient so far? Is there anything that is pending? Okay, you must ask this question about management. It is really important. Expectations. What does this patient expect? Or what does the team expect from this patient being in hospital? Are there any pending referrals or reviews? And what do you want me to do? This is another question that you must ask. What do you want me to do for this patient? The last question is also extremely important. And this will indicate to you how you prioritize this patient. Yeah? Are they stable or are they unstable? Okay. This is the difference between you seeing that patient immediately after handover or waiting for a few hours, right? Is anyone confused about this part?
Nothing on the chat.
Fantastic. Does everyone have a good overview of my preferred method of handover now?
Yes. It's pretty clear. Thank you.
Yeah, so in the study guide, it's a bit more comprehensive. I've taken that and I've further condensed it to the absolute minimum that you need to know or you need to say in the station. Okay, this is the absolute minimum. And if you do everything, and if you ask all these questions, you will pretty much pass the station if you prioritize well.
So somebody's asking, are we expected to give our possible management recommendations at all?
No, you don't have to. You just receiving a handover. You don't know anything about the patient. And it's a bit silly for someone to expect you to assess and manage a patient you've never met before in your life. Okay? What they're testing in the station is, number one, the communication skills, and number two, prioritization skills. And I can't really teach prioritization skills. What I could do is I could give a list of handover jobs, right? So I could share this at some point later in the chat, and just to have a background knowledge of how everyone is at prioritizing jobs. Yeah.
Han
Does that sound?
Sorry.
Does that sound okay to everyone?
Yeah. So Han is asking, what do we ask for diet?
Are they eating and drinking? Just ask, are they eating and drinking? Okay.
Yep.
Yeah. Does anyone have any questions about my prioritization plan? It's you can't really teach prioritization. It's just.
So Tammy's asking about discharge planning.
Discharge planning is a different station, and this is only on teamwork and handover.
So I have a question. Like the most common handover is for 3 patients. If I tell you the patients, you can tell us the prioritization for them.
Sorry, could you say that again?
The most common handover station which we have been looking here and there is like 3 patients, and if I tell you that, can you prioritize them for us for now, just like to be sure?
Yeah, okay, sure. I think it's very good that you're practicing with 3 patients. That's honestly what I did as well. So I prioritized with the upper range of normal. That would just make you a bit more comfortable in the exam if you are just given two cases. So that's really good. Practice with 2. Practice with 3. Sorry.
So if we have got a 30-year-old lady having subarachnoid hemorrhage, and we have got a 60-year-old patient having stroke, and then a young lady who is asthmatic already, and she has got cough. I think she has got pneumonia. Yeah.
Okay. Right. Can you tell me a little bit more about each of those patients? What's the situation with the 30-year-old? Is she conscious? What's the GCS?
She was conscious and stable, but her CT scan found out that she has got a subarachnoid hemorrhage. And the 60-year-old patient had weakness in his right side, and he has just been brought to the hospital and nothing has been done. And the one with cough and...
Sorry, Maniva, but the symptoms had developed 6 hours ago.
Yeah. Stroke patient.
Okay. So stroke patient has developed symptoms 6 hours ago. Yeah.
Yeah.
Right. So he's still in the No, he's out of the thrombolysis window. He's more like a stroke rehab patient now, isn't he?
Yes.
Right. So just from hearing, tell me something about the asthmatic patient. Is she saturating well? Okay.
Nebulizers right now. She's on nebulizer.
Sorry.
She's
on nebs.
Yeah.
She's on nebs, and our saturation's fine.
Yeah, I believe so.
Yeah. Any decrease in the peak flow?
No, I don't know. We're not reading about that.
Right. So I would prioritize the young lady, the 30-year-old with the subarachnoid hemorrhage. So refer to neurosurgeons for that one. Then go and do a stroke referral for the 60-year-old with a 6-hour history of new onset. What was it? Left-sided weakness?
The complete history from the brief is in the chat here.
Okay.
So Tammy is then asking if we prioritize by news and by GCS.
Okay, let me try and get the chat up.
I can read it to you if it's complicated though.
I don't really want to navigate away from this thing on my computer, so let's see. Okay, I can see it on my phone.
Okay.
Right. First patient, 30-year-old, Mrs. Black, headache, CT scan of the head. Worst headache of her life. Examination is normal. Okay. Why have they not done any investigations for this patient? This is a horrible hospital. Say that much. Asthmatic patient, returned from Germany, cough, tight in the chest. no other investigations has been done. So subarachnoid hemorrhage could potentially become much worse. And because of her age, I would still say that she needs to be urgently referred to neurosurgeons. Yeah. Then I'll prioritize a stroke patient. He's outside of the thrombolysis window. Thrombolysis window is 4.5 hours from onset of stroke. No investigations have been done so far. So do something and then refer to the stroke team. And the asthmatic patient is on nebulizers with no mention of anything to do with oxygen saturations, increased work of breathing, or any of the other alarm symptoms, as well as anything to do with peak flow. So I'll probably see her last. So let her finish the nebs, and then I'll go and see her. That's how I would prioritize it. Subarachnoid hemorrhage, really severe, especially in a 30-year-old. She's a good candidate for surgery. Neurosurgeons will want to know about it right away. Okay.
Yep.
Yeah. Did everyone arrive at the same answers, just by the way?
Yep.
Yep.
Yep. I don't like that hospitalist, by the way. I haven't done anything for the patient in 6 hours.
It's the Aspire Hospital.
No, this is every academic hospital. We have got this from Stanton as well.
All right, okay. So let's move on, yeah? So that is the essence of handover, yeah? So hopefully we'll leave handover behind and move on to teamwork. So teamwork, there are various ways in which teamwork can be tested. In this exam, they're usually looking at how well or how badly you communicate with members of your team, hence the word teamwork. It usually involves asking for a senior review or doing a referral to another specialty. There are some other ways that teamwork can be tested. This has never been tested before in these ways. Difficult colleague or presenting a case. So presenting a case, I'm assuming everyone has watched Geeky Medics videos, right? Yeah. So at the end, you know how they stand in front of the camera and present a case? That is exactly the way you present a case if this comes out. I do not expect it to come out, but that's the way you do it. Okay, exactly like that. You present the case in a systematic fashion, manner. Difficult colleague, I won't go into too much detail for it. This is usually tested in a variety of different questions on the SJT. At the very end of the session, I'll give you a framework on how to deal with a difficult colleague. It's good to go over, but I wouldn't learn it in depth. Happy with that?
Yep.
Yeah, okay.
So Irina is saying if you could name the videos, please.
The videos, so at the end of all the examination videos, on the Geeky Medics videos, they present the case and the examination findings in a structured manner. So any examination video, it's not necessarily the case, because it could be any case from medicine and all the medical specialties, from surgery and all the surgical specialties, and from psychiatry. So it could be any case. So it's just want you to let you know and familiarize yourself with how to do it. Don't learn the cases.
I have a question. So for a senior review or doing a referral, I'm assuming this is like doing, for example, at SPAR, then asking them to see the patient, or us referring the patient to them. Okay, thank you.
Yeah, so I'm gonna go over that now. So I will do a senior review case. I'll do a referral case with you right now. This is a practice case. Okay. It's a big ask. Does anyone want to have a crack at it? Okay.
I can go for it.
Yeah, sure. So this, by the way, this card will be with you in the station, and you can hold it with you and you can have it with you in your hands, while you're on the phone. This is what happens in your real life as well. So you have all your patient file, your nursing folder, your observation chart, your fluids, input, output. If you're lucky, you'll have a nurse there as well to support you, and you're on the phone to someone. Yeah?
Okay,
go for it.
Sorry, I'll just will I get my video. So do I need to read it out to you then, is it?
You can read it out aloud if that's what makes you more comfortable. You can do it whatever way you want.
Okay, you're the medical FY1 on Ward 1. Peter Dunbar is an 80-year-old male who was admitted with an infective exacerbation of COPD 2 days ago. He has a background of COPD, IHD, hypertension. He initially responded well to IV coamoxiclav, but now the staff nurse has asked you to review him urgently due to a blood pressure of 92/44, heart rate 122, respiratory rate 24, temperature of 38.5, O2 saturations of 87 on 28% Venturi, and a GCS of 13 out of 15, normally alert. You assessed him, prescribed 2 fluid boluses, taken blood cultures, switched him to piperacillin, tazobactam, have given IV paracetamol, and the nurses put him on a 15-litre non-rebreather oxygen mask. Unfortunately, he did not respond to treatment, and his saturations have come up to only 91%. Call an appropriate senior for advice. Okay, so am I pretending I'm on the phone to you?
Yeah, you can. So I will be your senior, but you don't know what senior I am, so you have to call an appropriate senior.
Okay, so I'm going to call the on-call medical reg. Hello, Dr. Singh.
Hi, MedReg.
Hello, Dr. Singh, or MedReg. My name is Luke. I'm one of the junior doctors on Ward 1. I just have a patient that I'd like to get some advice on, if that's okay.
Yeah, sure, go ahead.
Okay, so I have a patient. He's a Mr. Peter Dunbar. He's an 80-year-old male who was admitted with an infective exacerbation of COPD 2 days ago. And I'm concerned about his obs, essentially. I'm worried that he might be septic. So he currently, his vitals are blood pressure 92/44, heart rate of 122, respiratory rate 24, and his temperature is 38.5. His O2 sats were 87 on 28 or on Venturi, but his GCS is all right.
What's his blood pressure?
Is 92/44.
Mm-hmm.
So he's on a background of COPD, ischemic heart disease, and hypertension. What we did when he came in is we gave him IV coamoxiclav. He initially responded quite well, but when I've gone to review him on advice of the nurse, he's deteriorated a bit. What I've done since is I've assessed him, prescribed 2 fluid boluses, taken some blood cultures, and switched him over to tazocin. I've also given some IV paracetamol for his fever, and then the nurse also put him on a 15-litre non-rebreather oxygen mask. Unfortunately, he's not responding as well as we'd hoped, and his saturations have only come up to 91%, so I was hoping you might be able to give me some advice on what we should do next.
Yeah, he sounds really sick. I'll come over and review him myself. Could you please stay there and get the drug chart ready for me?
I will.
Yeah, thank you.
Thanks.
That was fantastic, Luke. That is 100% in that station.
Cool. I just read most of it.
Yeah, and that is exactly what you do. You take whatever's been given to you and you paraphrase it.
Mm-hmm.
Yeah, so that's my example, and I use the S-bar example. But you were very good. So you introduced yourself. You made sure that medical registrar was named, so that the appropriate senior bit has been clarified. You introduced yourself. You gave a little bit about your situation. You said you're on Ward 1, or you're calling about so and so. Yeah, you gave a good background of the patient, and yeah, you gave everything in the background, and that's basically you copy and you paste from your task. Just tell them whatever's there. The assessment, you've given your probable diagnosis. You've given what you've done, and the results of those of that assessment. So that was well done, and it was really good that you asked Did you ask me to come and see the patient, or did you ask for advice? You asked for something.
Ask for advice, yeah.
You asked for advice, but it's very good that you asked for something at the end, and that is the essentials. Very well done.
Thanks.
Yeah. Does anyone else have any questions about this?
I do have a question, just because I took the class a while ago and I had a telephone conversation question, and I don't know what I did wrong, but apparently I failed the station. So I was wondering if there's also bits where you're assessed on, sort of like communication. Are you asking to see if your colleague actually understands what you're saying, or is this just because this is a med-reg situation where the person should actually know what you're talking about? Just so assuming it was, let's say, maybe you're talking to a HCA, for example, and they don't really understand the terms. So is there a point where you're meant to check understanding or to sort of be cautious and things like that?
Yeah, so the person that you're talking about is very important. In this case, because it was F1 talking to the med-reg, you're not really concerned if you're using a lot of technical terminology, because the med-reg will definitely know all of that. But if you're talking to your junior colleague, or nursing staff or healthcare staff or other allied healthcare workers like physiotherapy, you do need to clarify and make sure that they understand or they are on the same page as you. Okay, I'm not really sure about your station or why you unfortunately didn't make it on that station, but that's the way you do things in general. You have to clarify. And you have to be very aware of the person that you're talking to.
Okay. So I was also concerned because this was it was almost like a one-way conversation. So he pretty much gave you everything and then you're like, oh, you're coming over. But I'm just wondering if that was an exam situation, you probably might have spent, let's say, 2-3 minutes, and then you're just sitting down for the rest of the station. So it might kind of freak you out. So I'm just trying to make sure you're not missing anything.
No. So the other thing that I want to make sure that everyone knows about the station is that Luke didn't make anything up. Yeah. If you speak extremely fast, which he didn't do, you will finish the station a bit early. So go slowly, okay? You have that entire 1 minute beforehand. Take that entire minute. When you go in, don't just rush. Sit with your card, read it properly, a good time before you pick up your phone. So you read the task on this, outside the door, whatever, when you go in, and inside the station or on Zoom or whatever. I'm not sure how it's been done now. So you'll have the task again, read it, like comprehend it well, and then go to do your thing. Because once you start, you cannot stop and you can't go back and you can't backtrace. Okay, so you have to show that you have a good flow. I made mistakes lots of times in the station. Thankfully, I passed. But what I did was, in some stations, I was just too quick. Maybe that's a feature of my character. I don't know. But slow down. Okay, you have enough time. In this station particularly, you have time. It's not one of those stations like prescription or acute management where you're really rushed for time and you need to be quick.
Okay, thanks.
Yeah. So the important takeaway points for this is a good structure. For this, the structure that everyone tends to use, regardless of specialty, is the SBAR technique. So situation, where are you and who are you? The background, everything about the background of your patient, including your observations, which you need to say everything. You need to tell the med-reg or whoever all the observations. Your assessment, your probable diagnosis, your working diagnosis, or what you've the conclusion you've come to at the end of your assessment, what you have done, and what has happened after you've given those interventions. Yeah, and that's in your assessment bit. And your recommendation, what do you want the med-reg to do? Are you asking for advice? Are you asking for a review? What do you want them to do? I hope that's clear.
Yeah.
Okay. It's a very easy station. It's just paraphrasing all of this and putting it in a nice little format, a nice little framework, and regurgitating it again. The main thing you should not do, and this is extremely important, do not make things up. Right? Do not make up results of investigations or imaginary background problems, or so no regular medications were mentioned anywhere in the station. But if now you had to go and say something about this patient, like he's on Ramipro and he's on sitagliptin, you're making things up, okay? And you do not do this, you will be marked down for that. Right, any questions about that?
So in the exam, if the other person asks us a question about something that we don't know, like you just mentioned drugs, and they're not written on the card or whatever information we have, how will we respond to that in the exam situation?
Say, I don't have that information in front of me right now, but I can find out and get back to you. Is that okay? Okay.
Okay,
Yes.
thank you.
Yeah, okay. That's an example of asking for a senior review. The next case is a referral practice case. Is anyone brave enough to try it?
Can I try?
Yeah, sure, go ahead.
Okay.
So you take as much time as you need, take as much time as you want. Remember, you have all the time in the world. You can read it out if you want.
You are the surgical FY1 on Ward 12. Margaret Cousins is a 57-year-old female who was admitted with a right neck of femur fracture 3 days ago. She has a background of hypertension for which she is taking 5 milligrams of amlodipine. She's a heavy smoker and smokes 30 cigarettes a day. Her surgery went well, however, there was an incidental finding of a corrected calcium level of 2.92 millimole per liter. That's high. This prompted a CT scan of her thorax, and a suspicion lesion in her left lung was demonstrated on the scan. Your consultant is concerned about the possibility of cancer. Make a referral to an appropriate speciality.
Okay. So this is a telephone referral.
Okay. So sorry, I just want to ask before starting. Do we decide who we're referring to, and then how do we let the examiner know? So it just be like, hello.
So you would say, hello, is this the, or hello, am I speaking to?
Okay. Okay. Shall I start?
Yeah, go on.
Okay. Hello. I'm Dr. Ijaz, one of the FY1s in the surgical department. Am I talking to the MedReg?
Speaking.
Okay, so I just wanted to discuss a case with you that we came across. It's a 57-year-old lady who was admitted with a fracture of the right neck of her femur 3 days ago. She underwent her surgery, but we found an incidental finding of a raised calcium level of 2.92. So we then requested a CT scan of her thorax, and we've seen a suspicious lesion in her left lung. The consultants are just worried about the possibility of it being something sinister like cancer. In her past medical history, she's got a background of hypertension, and she's taking 5 milligrams of amlodipine for that. She's also a heavy smoker. She smokes 30 cigarettes a day. Her surgery and her recovery are going well so far. There are no issues with that. It's just this is what we're worried about.
Can I just ask, that elevated calcium level, is she experiencing any Is she experiencing anything from it? Is she ill because of that calcium level?
No, it was just an incidental finding.
Right. I'm not sure why you call the med reg. I think this might be more appropriate for the respiratory registrar on call.
Okay.
Right.
Sorry.
Okay. So that was really, really good. You gave everything and you incorporated everything in the SBAR technique, and that was excellent. The only thing that went wrong is that you referred to the inappropriate specialty. So the word specialty here is a clue. It has to be something that is specialist. So remember again where you are. You are surgical F1 on ward 12. You're probably the TNO F1. Yeah. So you're faced with this patient, the high calcium level, probably parathyroid related peptide. She's a heavy smoker. Yeah, you've got a CT scan in front of you and a suspicious mass. Your consultant is worried, your team is worried, could be cancer. There's a bit of panic going on that ward, surgical ward. So now it's your job to make a referral to an appropriate specialty. So you have to think about where you are, what you have in front of you, and what you want to do. Because this lesion is in the lung, it's respiratory. Yeah, so the med reg will be the med reg on call, and if you do this in real life, they might get a bit irritated with you. Okay, so this is a job for the respiratory registrar. And if at any time you're not too sure who you should be referring to, just think about who you are and where you are and what you have in front of you and what you've been asked to do. Those three things, and you'll get the answer. Okay, but it was really, really well done. Yeah.
Just a question. When we're referring, we always refer to the registrar before speaking to a consultant. Is that correct?
Yes, always a registrar. Okay.
Okay, I was just under the illusion that we have to go through the medical registrar before we go into any further subspecialty, but that's not the case.
No, that's not the case. Yeah.
Okay, that's fine.
Usually, I just use an example of cancer referrals. When you start working here, you'll understand that the 2-week cancer pathway is traditionally for a GP to refer under the 2-week pathway to a specialty. When patients like this are in the NHS, it's done a little bit quicker, about a week, but it has to be done like a proper paper pro forma, and it's a whole lot of admin work to do. Sometimes it's done, you do the paper referral and then you pick up the phone to the surgical reg and say, hi, I'm so-and-so, I've just sent off a referral. Do we know when we'll get any results of the MDT back? Yeah. But this is a really good case. This is a good potential case of asking for a referral. Okay, any questions?
I was gonna say oncology registrar instead of respiratory. Would that be okay, or would you just go with the respiratory registrar?
I would go with resp because the lesion is in the lung. So oncology in the NHS is paired with hematology here.
Right.
And there are other various types of oncology services like acute oncology and palliative. So the first person to go to anything in the lungs is respiratory. I wouldn't speak to oncology.
Okay, thanks.
In the recommendation part, do we always ask for that what they'd like us to do, or would they like to take over the patient? How do we go about that? Because like in the country I come from, where, for example, if this scenario arises, the surgical team wouldn't do anything themselves. They'd expect the respiratory team would come and take over, and that's what a referral would be. So how does it work in the UK?
How it works in the UK is this
what
patient
would we say,
is...
When I'm talking to the respiratory registrar, what would I say? That what do you want us to do further, or would you like to have a look? Like in the recommendation part, how do we address that?
I would do it exactly as I've outlined it here. The reason for that is in the UK, they are named consultants, right? So again, where are you? You're the FY1 on a surgical board. The consultant that this patient is admitted under is a surgical consultant. That is the parent team. And until that patient is formally moved from the system, whatever system they use, Lorenzo or whatever, to a respiratory consultant, you are still the parent team, and you should still be doing it. So if the respiratory team wants you to do some further strange investigations, they want you to do like parathyroid hormone levels and vitamin D levels, that is your job to do, because that patient is still on a surgical ward.
Okay, thank you.
Yeah. I would, under the recommendation, I would say it in exactly the same way. Can we kindly refer this patient to the respiratory team for further investigation and management? And is there anything else you'd like me to do in the meantime?
I have a question. If you have a hospital that has a thoracic ward or thoracic department, would that also be an appropriate place to call?
Thoracics and cardiothoracics is another surgical team. So you really need respiratory for this because it's medicine, it's cancer.
Okay.
And respiratory will then work with thoracics and cardiothoracics if the cancer is appropriate to be excised.
Okay, thank you.
Okay, anything else?
Nothing on the chat.
Fantastic. So that's the last bit about teamwork, and I will just go through very, very briefly a framework for dealing with a difficult colleague. This is an important communication skill, and again, communication is something it can't really be taught, but it can definitely be practiced and improved upon. So I will be sharing, I do tend to share anything I find interesting in the Telegram chat. And right now I'm in RCA for the MRCP exam group. Don't know how I get into these groups, or someone just invited me. And although the communication scenarios are tailored towards a different exam, the technique that is used is universal, okay? So just go through the videos and the clips that I share. That's really, really helpful, okay? So the framework for dealing with a difficult colleague, you can use the PACES framework. Under the PACES framework, the P is probing for better understanding. Why has this happened? Why is this person acting in this way? Why is he or she saying this, and why are they doing this? So you can't begin to solve a problem without understanding the issue first. The A stands for alert. Say alert to danger. Has this issue arisen before? Were there previous issues with this person? And what was the outcomes of those issues? Are they continuously getting into problems or causing problems with the service? C is challenge. So when you challenge someone, you don't do it rudely, and you don't do it from a place of anger. When you challenge someone, you do it in the most polite way possible. You start off by saying, I'm very sorry, but I do not agree. I'm very sorry, but I don't feel the same way. So I'm very sorry, but I beg to differ. Okay, that's how you challenge someone. E stands for emergency. It's an emergency warning. So you're giving them a bit of a warning as to what you're going to say next. So remember, you've challenged already. Say, I'm very sorry, but I don't agree with what you're saying. And I don't feel that this is the right way to speak to me. And S, if all else fails, you say you want to escalate to a senior. But that should be your absolute last step. So the first, pace yourself from the first part of PACES. And try and talk things through. Most people are very, very sensible. They do not want to escalate issues. There are very few people who actually want to fight with you, but you will come across those rare people in your practice. And these are colleagues as well, F1s, that are very, very combative for some reason, competitive. I don't know where it stems from. But the absolute last point is escalate to a senior. Because once you escalate to a senior, that is already there, out there. And that will just get either sorted out at an appropriate level, or it will be escalated further. Okay? So any question with dealing with a difficult colleague? This is not a teaching station. It's just a framework that will hopefully give you a better understanding on some of the steps in dealing with a difficult colleague if you do ever come across a difficult colleague, and it can be incorporated into any of your communication stations. Any questions about this?
I do know a different framework. This one does seem quite different. So it seems as if this is sort of dealing with a problem, a confrontational problem. But I do know another framework, the SPICE framework. So that one sort of So do they work in different scenarios, or can one be interchanged with the other?
No, you can use any framework that you want. Okay, anything that you want.
Someone is asking, Irina is asking if you could please repeat the A meaning.
The A meaning is alerting to any dangers or any issues that may have arisen previously when dealing with this person. So have there been any previous issues? Has issues been escalated before? Have other colleagues experienced issues with this person? Okay, just a general feeling of what this person is and where they're coming from.
Sorry, so how would you ask for previous issues? Do you ask them?
You can, so remember, this is a framework. This is not something that you follow religiously when you're dealing with a difficult person in a communication station. This is a lot for real life as well. And in real life, you don't really have to ask, have you had any problems with anyone before? Because most people will be very confrontational when asked for that, and they'll be like, why are you asking me this? What are you accusing me of? What's your aim here, right? So this is a lot for real life, as well as just to get you for a better understanding on how to deal with a difficult colleague. Okay, you don't have to ask outright, have there been any previous issues? Okay, your task might mention something like there've been, so if talking about a patient, it might be, this is a frequent attender, or he has assaulted a member of staff before, or previous issues with the law, problems with the law. So that would be an alert to danger, okay?
So someone is asking, so you do the British thing and you just keep saying sorry?
Yes, you do the British thing and you just keep saying sorry and be extremely polite. That's what they want, and that's what you will give them. Okay. Anything else, or any other questions about anything else with teamwork or handover?
There was one question at the beginning that I didn't pass through. That was if you could say a brief and composed way to introduce yourself and start a station.
I think I've spoken about this before in my assessment guideline. It's very generic, so you would say, hi, my name is Sarishka, I'm the F2 on psychiatry. Well, say, hi, my name is Sarishka, I'm one of the F1s, or I'm one of the F2s, or one of the junior doctors. And you have to say your name. They generally don't like you to introduce yourself as doctor here, so I would never say my name is Dr. Singh, unless dealing with a difficult patient when I want them to know I'm the doctor. So I would always say, hi, my name is Sarishka. Hi, my name is Shah. I'm the F2 on call. How can I help you?
Another question is, please going back to the case that Luke practiced with you, if you get the diagnosis assessment of what you think the patient has wrong, would you fail the station?
Just say that again. Which one was it?
So the request for a senior review. It says, if you get the diagnosis/assessment of what you think the patient has wrong, would you fail the station?
No, you would not fail the station. If you got everything else correctly, you would not fail the station. Just say, I think the problem is, I think it's most likely, I have a suspicion it is, and then just go on with it. It will be fairly obvious. I think the assessments will be very, very obvious. In this one, it's really obvious. It's sepsis, yeah? So it won't give you a complicated diagnostic scenario. It will be very simple, very straightforward, something at the level of an F1.
There's no more questions in the chat.
Okay, so if there's no more questions, thank you everyone very much for attending the session. I really hope it has helped. If I could just ask everyone that attended today to please fill out a feedback form that I will be sending very shortly in the chat. Okay?
Yes.
All right.
Yeah. Thank you, Srushka.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you. Thank you.
We
Thank
love
you.
Thank you so much.
Fan club.